Hi everyone. This is the narrated PowerPoint that goes with um, lab this week and last week, which would be respiratory anatomy and physiology. So I'm going to go through the respiratory anatomy portion with you. Excuse me, but you already had, like I said, you already had this last time I met with you in lab. So you can skip ahead if you want to skip to the respiratory physiology part. But this information is exercise 36, and so that's what I'm going to go. I'm going to go through kind of fast because that's stuff we already discussed. And then we'll talk a little bit more about the physiology in exercise 37. And then PhysioX exercise 7 is something that you'll be completing as soon as we all have access to this this access code that we've been working on. So let's get started. So there are really four different jobs or four different functions or activities going on at any given time with the respiratory system. One job is to change our exchange gases, so gas exchange, get oxygen into the bloodstream, carbon dioxide out. We do this through the process of pulmonary ventilation, and the exchange of gases between the bloodstream and the lung is known as external respiration, and the exchange of gases between the tissues and the bloodstream is known as internal respiration. The structures you see on this page are kind of lined up in order of steps if you're going to follow a molecule of air. So our upper respiratory system structures, we're talking about the nose, the paranasal sinuses, the pharynx, larynx, trachea, down into our branches, and beyond bronchioles would be our alveoli. So here are the membranes involved. Excuse me. The whole system is going to be lined with epithelial tissue. It just kind of transitions from one epithelial tissue type to the other as we go through. So the nasal cavity, nasopharynx, that's going to have the pseudostratified columnar ciliated epithelium. You can see those goblet cells in there, those little yellow guys. Oh, I forgot that I can do this. So these yellow blobs are goblet cells. So those are going to help secrete mucus, which is going to trap foreign particles. And then the cilia at the top are going to be able to sweep, that's not where it is, sweep those materials along and get them out of the body and get them out of the lung. The second section here that we have is the rest of the pharynx. And so we're looking at stratified squamous epithelium. The main reason there is because food is going to be shared at least partially in this area. And food can be rough. Think about a potato chip that you ate that you didn't chew all the way. That can definitely cause some damage to the back of the throat. And so that stratified squamous epithelium is going to have a little bit more of a protection in that way. So then going forward to the respiratory mucosa, middle section here, larynx, trachea, and large bronchial passageways, we still have that ciliated, pseudostratified ciliated columnar epithelium. Once we start getting into the smaller airways, we start seeing some cuboidal. Simple squamous is our last stop. That would be kind of our alveoli. But yeah, so it's all epithelial tissue. Epithelial tissue has the ability to regenerate, which is awesome. So if our lungs do have an infection or we have damage to the lung, they can mature or they can repair themselves to a degree. The next slide discusses the structures of the skull and the nasal cavity and nose. The nares are going to be your nostrils. We already discussed the nasal cavity quite a bit. And we have our nasal conchae. So you can see your nasal conchae inside the nose here. sorry, this area right in here, let's try again, right here and right here. These little projections you see on the sides are known as your nasal conchae, and those nasal conchae are very easy to see when you look inside of the nose structure of a skull. Those nasal conchae have a role in humidifying, moistening, and filtering the air as it enters the respiratory system. We had spaces called paranasal sinuses. Let me just check really quickly if I have the picture on the next slide. Yes. No. Yes. So we'll talk about that in a second. And then we have our hard and soft palate, which are the structures that are going to make up the bottom of the nasal cavity, but the top of the oral cavity. This is our structure, our side view, sagittal section is what I'm trying to say, I'm sorry. And we have our nares right here. We have the nasal conchae right here and here and here. And then these spaces are sinuses. And then this down here is the palate, hard palate in the front, soft palate in the back. All right, nasal sinuses, paranasal sinuses. So para means beside, and all the sinuses are continuous with the nasal cavity. So these are all going to eventually drain into the nasal cavity. This is why we have such congestion. Sinus infection is going to lead to mucus secretions out of the nose. So these are going to be named according to the bones that they are in. So this guy right here and this one right here are known as your frontal sinuses because they're in the frontal bone. These right here are the maxillary sinuses because they are in the maxillary bone. We also have ethmoid and sphenoid sinuses, and these are kind of be, sort of at the bridge of your nose-ish, right in here. All right, moving forward, we have the structure of the pharynx and the larynx. The throat the pharynx really has three different parts. This top region here is the nasopharynx. The middle region here is the oropharynx. And then the lower region is the laryngopharynx. And they have different epithelial tissue types in each section. The nasopharynx is going to have pseudostratified again. Oropharynx is stratified, and laryngopharynx is back to stratified. So these are things, or continued to be stratified. So these are things that, the reasons for these is because of the need. So the oropharynx and laryngopharynx are going to, be exposed to food. So again, that's that stratified squamous. Nasopharynx, oropharynx, laryngopharynx. Not much else to say here about these structures. This slide discusses the tonsils. So looking at some of our structures, your tonsils are going to sit back here. This is also a tonsil, it's just enlarged. These tonsils in here are known as the palatine tonsils. There are tonsils that are located in the nasal cavity, known as your adenoids, also known as pharyngeal tonsils. And then we also have a tonsil set at the base of the tongue, known as the lingual tonsil. So when you get a chance, you can check out these surgeries and these videos. I think the first one is pretty nasty. Tonsil lifts. So tonsil lifts are stones. Lith means stone. So they're tonsil stones. There are, because the tonsils are lymphatic tissue, they have a lot of grooves, and the structure of it allows for buildup of minerals and bacteria. And so sometimes people get a stone. And so that's there just kind of for shock and awe, I guess. There's a tonsil surgery. There's an animation of that surgery. So if you're interested, feel free to check it out. And these are those 3 tonsils that I was just mentioning. So the pharyngeal tonsils right here, also known as adenoid, the palatine tonsil here, and then the lingual tonsil here. So 3 different sets. Job is really clean that air as it's entering into the body. There's going to be cells there that are, that are going to be immune cells, and they're going to be trying to catch things as they go by. We don't want anything down into our lungs that doesn't belong there, because that's going to have a direct connection with our capillaries in our bloodstream. This is the pharynx and the larynx. Continuing along, we're at the larynx now, and I'll give you a page number for this. In lab, we spent some time with this. Sorry. I wanted to give you a page number. 534 in your lab manual. I'm sorry, I apologize. All right, and so we have our hyoid bone right here. And then we have a lot of ligamentous material. And then we have 9 cartilages. Thyroid cartilage, cricoid cartilage are the 2 that you're the most responsible for. So that's going to be, this guy is cricoid, this big one is thyroid, and the laryngeal prominence is the Adam's apple. That's what we would call it, the Adam's apple. So then this term glottis simply refers to the hole leading into the trachea. Okay, that was hard. Okay, and so your epiglottis is right here, and this is a flap of elastic cartilage, and it will close the glottis, epiglottis meaning above the glottis. It will close the glottis when food enters that area, because we do not want food going down the glottis. So this is going to cover the glottis and reroute the food to the esophagus, which sits behind it. And so the epiglottis is made of elastic cartilage, and these other cartilages are made of hyaline cartilage. It's supposed to say hyaline, H-Y-A-L-I-N-E. The last thing on this slide here is just a discussion of the vocal cords. I'll show you that in a couple of slides, so hold on a second. This one is going to be epiglottis. All right, so this is a posterior view, and we have our epiglottis right here. Epiglottis elastic cartilage, epiglottis elastic. Here's the hyoid back here, kind of looping its way around. And then here's the structures that we've been mentioning. So here's your thyroid cartilage again. Let me get my highlighter. This is thyroid cartilage. This is cricoid cartilage. I believe on your lab sheet from Dr. Maielli, give me 1 second. I think he wants you to know, yes, arytenoid cartilage. So your arytenoid cartilage are these little triangle shaped ones back here, also hyaline cartilage. So of note would be this section back here, especially important. These are cartilages of the trachea. They are C-shaped. They go all the way around the front and loop around to the sides. They do not close in the back. So these are hyaline cartilage, C-shaped structures that encircle the trachea, but along the back, they do not connect. Instead, this is musculature. And the reason for this is because the esophagus is going to come right along behind the trachea, and it butts right up against it. It's very difficult to draw a straight line with this mouse. I'm going to try it like this. Yay, a little bit better. So the esophagus kind of butts right against it, and that esophagus is going to possibly have to enlarge due to a big bolus of food, and so that bolus is going to be pressing against the trachea in that location. If those rings were hard all the way around, then that's going to prevent the esophagus from expanding the way it needs to. It's also going to possibly harm the esophagus by banging against a hard structure, because hyaline cartilage is really hard. But the C-shaped structures for the trachea, they provide a lot of stability, keeping it open. This is the diagram. I have a very similar diagram for my lecture, but this area down in here is the glottis, or this opening is the glottis, and what I'm highlighting is the inside past the glottis, which is the trachea. So we're seeing those rings of the trachea right here. You can see them really well on sheet pluck, if you've ever done a sheet pluck dissection or if there's one available in the lab. I'm going to highlight the epiglottis blue. So this is all epiglottis. We're looking at it obviously from the top now. And these are the vocal cords, right here and here, here and here. Those are called true vocal cords. And then the, I'm going to color it purple, the structure out in here are known as the false vocal cords. Sometimes they're called folds. All right, so we're just worried about the function really of these structures. The vocal cords are obviously involved with speech. They are going to vibrate. You don't need to know the physiology of all that at this point, but just know that the vocal cords are on either side of, they actually form the glottis. So that when the glottis opens, or when they open, the glottis forms. It's like the iris of the eye. I mean, it's the iris forms the pupil, so it's the same. All right, this is just a couple of videos that are kind of fun to watch, but these are the vocal cords right here. So laryngoscopy, which is awesome to see with a camera. You can see singing, and there's a surgery. Some people get vocal nodules and they need to have them removed. So we hear about that a lot with singers. And then down in here is the glottis, and if you look really closely, you can sort of see the rings. I can't highlight it, but you can see the rings of the trachea. Moving forward to our trachea, about 11 centimeters long. It's not a huge structure. We already discussed those C-shaped rings. We know that the trachea is lined with pseudostratified ciliated columnar epithelium. And at the base of the trachea, so the trachea is a Y, an upside down Y, we have the trachea, and then we have branching. This is going to be the primary bronchi. But the place where that Y starts to branch is known as the carina. So that's important to know. These are the structures I wanted to point out to you. So up here we have our epiglottis, our larynx. This is going to be our thyroid cartilage. Cricoid cartilage would be in here somewhere. Here's all of our rings of our trachea. And then this location is the carina, right where it's going to bend to become the left primary bronchus and right primary bronchus. Sometimes we call them main stem bronchi. Those two are going to have a distinctly different structure because here we would have the heart. And so what this means is that, let me color my heart in here. What this means is that this bronchus, the left main stem bronchus or left primary bronchus, is going to have to be a little bit more horizontal rather than vertical. So it's going to be more this way, whereas the right one will be more this way because of the fact that we have this heart in the way. The respiratory tree, this picture shows it much better. We can see that very sharp, more vertical structure on the right side versus more horizontal structure on the left side. The left side also only has 2 lobes. The left lung only has 2 lobes because of the heart, and the right lung has 3 lobes. And this is known as the respiratory tree because, for obvious reason. Once we get past the trachea and the bronchi, we enter into smaller and smaller and smaller bronchi, secondary, tertiary bronchi, and we get into respiratory bronchioles. So bronchioles are really, I'm sorry, after we get into tertiary bronchi, we get into bronchioles. After the terminal bronchiole, we have what we call respiratory bronchioles. And those are going to have alveolar sacs on them. Alveolar ducts on them, as well as alveolar sacs and alveoli. So the sac is kind of this whole section, and one alveolus is one of these little purple balls. It was supposed to be purple, black, purple. So one of these little purple balls, an individual one, is an alveolus. These you would only see microscopically. You wouldn't be able to see this structure. Right up here is going to be our carina once again, and here's our bronchi. So our bronchi, once they branch, we then use the term secondary bronchi. Sometimes those are called lobar bronchi. So our primary bronchi, also known as main bronchi, right here. Oops, I want to do that color. There we go. Main bronchi. Enter the lungs at a place called the hilum. So now I'm going to have to show you a slide in a little bit to help clarify what the hilum is. We'll do that in a few slides. So the right primary bronchus, like I mentioned, is wider. I didn't mention that it was wider, but it's much more vertical, so it doesn't have to go around the heart like this one does. And so that makes it, it has the ability to be wider and a little bit shorter before it starts to branch. Your lobar bronchi, the second ones, secondary bronchi, there are 5 total. So we have 5 secondary bronchi total. So we have 2 on the left, 3 on the right. Excuse me. And then those become tertiary bronchi, which eventually become very small bronchi, bronchioles, terminal bronchioles, and then respiratory bronchioles. And that's where we were at with the last slide, where we were discussing the alveoli. So here's a little diagram of our alveoli. You're looking at your arteries and veins, so pulmonary arteries and veins eventually bringing blood flow to and from the alveolar structure. So this is going to be made of simple squamous epithelium so that there's a single wall. The alveolus is a single wall, and then the capillaries are also a single wall. And so when the capillaries kind of butt right up against the alveolus, and this guy is a capillary, exchange between the two is very easy because they're both one layer. So the alveolus can, oops. Okay, that didn't work. Sorry about that. So let me restart this slide. Is there a way to do that? I don't know how. No, there's not. That's okay. I'm going to just keep going. All right. So if we have an alveolus, one little alveoli would be multiple, and it's surrounded by these capillaries, which you see here look like all these little strings. Gas exchange between them is going to be really easy. Sorry, this slide is a big mess up. But at any rate, this is going to allow for gas exchange. So the more surface area we have with these little bubbles, the more capillaries can touch that surface, and the faster this gas exchange can happen. The pleura are the linings around the lungs. I have a picture on the next slide that I'll show you. The lab manual is very, very, it doesn't have a lot in this chapter. There's a little bit of this going on with the visceral and parietal pleura on page 536. There's a little bit of labeling pleural cavity. but it does have the hilum there, which we'll talk about. So the pleura are the serous membranes that line the surface and line the surface of the lung and line the surface of the lung cavity. The word parietal refers to the actual cavity, and the word visceral refers to on the tissue itself. So parietal pleura lines the thoracic cavity. Visceral pleura sits on the lung. And in between those two, there's a space called the pleural space or pleural cavity. These layers are not fused together, What that means is that there is a space in between called the pleural cavity. And so this is the pleural membranes, the pleural cavity, all of this is going to house the serous membrane and that serous fluid. So the serous fluid is going to allow for the lung to move around frictionlessly as it's moving in that, in and out forever in that cavity. This is the slide I was referring to. So the visceral pleura is your inner lining. Parietal pleura is the outer layer, both made of serous membrane, which is epithelial tissue. Both are going to secrete serous fluid. Right in here, it's a good time to mention what the hilum is. This area right in here. So the place where the bronchi kind of insert into the lung tissue is known as the hilum. That spot also is going to be the place where the pulmonary arteries and veins are going to plug in, I say. The kidney, the hilum is, so if this is my kidney, the place where the renal artery, renal vein, ureter, the place where those all come together is known as the hilum on the kidney. So hilum just refers to this section right here, where we have some structures plugging into another structure. The structure of the lung itself. All right, when you look at the lung, it has this sort of shape. The top here is, it should be more pointed. I wish I could just erase. No, I can't. So the top there is a little bit, it should be a little bit more pointed than it is. So the top is known as the apex. Remember we said that the apex of any organ is always the pointiest part. The bottom section here is known as the base. And the base sits on the diaphragm. So the diaphragm is going to sit under the lungs and the base kind of rests upon that. So this would be like the diaphragm and this would be our other lung. So in the costal surfaces are the outer surfaces, the surfaces that are going to touch the ribs. So all these areas. We already talked about the hilum. So if this is our trachea and these are our, initial primary bronchi branches, then this location here and this location here are going to be the hila. So then try to recall that the left lung has two lobes. Actually, it has, that's not right. I'm sorry. Let me erase that. Okay. So if this is our lung, we do have a little notch kind of built in. It's not that dramatic. It's more like this. But that notch is called the cardiac notch. So right in here is our cardiac notch. And then what this does is it sort of only allows the left lung to have two lobes. There's not enough room for three. Right lung has three. And these divisions are known as fissures, these little lines I'm drawing. All right, so here's our apex at the top. Into yellow. Apex at the top. So this section here, and this would be considered the apex. The base is the bottom area. And then we have our lobes. Left upper lobe, left lower lobe. Right upper lobe, right middle lobe, right lower lobe. And then these are the fissures. This is the horizontal fissure. This is the oblique fissure. And then the left side only has one because we only have 2 lobes, so we don't need 2 fissures. So this is the oblique fissure. Oblique means at an angle. And then here's the cardiac notch that I tried desperately to draw. Didn't do a good job. Trachea, carina right here, bronchi, which will extend, and then the hilum would be those locations where it plugs in. Medial view of the lung. This picture is on 536 in your lab manual as well. This is going to give us a nice view of that hilum. So this whole area right in here is the hilum, and erasing that, we have pulmonary arteries and veins, and then this is going to be your bronchi. Something we discussed quite a bit in lecture that I emphasized was the difference between conducting zone and respiratory zone structures. So remember that the conducting zone structures are just structures that are going to bring the air into the body and bring it down to the level of the alveoli. Respiratory zone structures are going to be after their terminal bronchioles. So make sure on any model or diagram you can identify these structures. Nares would be your nostrils. Nasal cavity, hopefully you know where that is. The septum is going to divide it. Your nasal conchae would be the ridges on the inside of the nasal cavity. Paranasal sinuses are going to be air spaces in multiple places around the nose. Hard and soft palate are going to form the top of the roof of the, the floor of the nasal cavity, the roof of the mouth. Remember, the hard palate is made of bone and the soft palate is made of muscle. The 3 regions of our pharynx, which are oropharynx, laryngopharynx, and nasopharynx. I did not do that in order, but naso is first. The larynx and the associated structures, we're talking about epiglottis, glottis, cricoid, thyroid cartilages, vocal cords, and also for the pharynx, you should definitely know, obviously the tonsils. So your trachea and where it divides the carina, your bronchi, primary and secondary. For lecture, I also wanted you to know tertiary. You have the hilum of the lung, we discussed multiple times, or the hilum, bronchioles, alveoli, and then the pleura, were the membranes. Microscopically, you're not going to be responsible for this. We're not in the lab, so we can't be looking under microscopes right now. But as a throwback to AMP1, hyaline cartilage looks like this. These are all chondrocytes that you have. And then what you're looking at down here is tissue, connective tissue that will lead to our pseudostratified ciliated columnar epithelium. And this space here that I'm going to color green, this space is the lumen of the trachea. So this hyaline cartilage would be one of the rings. All right, so examining the microscopic anatomy of the lungs. Again, unfortunately, we're not going to be doing this, but I do want you to understand, or at least be able to notice the differences. So we're looking at the level of the alveoli in each of these slides. Normal alveolar tissue is going to have, if you can picture a tennis ball that's hollow, that you cut in half, that's what you're going to see, with kind of a concave structure in here. So this is an alveolus. When we do a section of it, that's what we see. So we see, a lot of these curved structures. They're probably not going to go all the way around, but they're going to be pretty intact. And then you'll see some open spaces that are going to refer to, or that are going to be the ducts and possibly bronchioles and simple squamous epithelium. So that's what we should see. What we see in this slide down here, the second one, this stuff is cancer. So when tissue becomes cancerous, it overgrows It does not look the way it used to, and it does not perform the job that it used to. And so looking at that mess that I just made, the second slide down is going to be cancerous tissue. So this is normal, this is cancer, and down here, this is emphysema. Emphysema, the walls are broken. So emphysema, you'll see a lot of open space. Cancer, you'll see a lot of tumor and filled in space, and then normal tissue will have kind of a blend of the two. So now we're moving into the physiology. And so your lab exercise pretty much ended, exercise 36 ended here, or ended just there, and then this is the respiratory system physiology. This is pretty much where 37 begins, exercise 37 begins. And so we need to make sure that we understand some of this stuff before we move forward to the last part of lab, which is the physio-X exercise. Okay, and so really important to understand how inspiration happens and how expiration happens. In inspiration, we also call that inhalation. That's what we're seeing here. In inhalation, we have the rib cage moving out and up. Did not work out very well. Okay, so the rib cage is moving out and up in the case of inspiration. We're also going to see the diaphragm dropping down. So what all of these arrows mean is that, and the sternum moves out as well. So we're dropping the diaphragm, widening the thoracic cavity and raising the ribs. You're enlarging this area quite a bit. And what that does is it causes air to rush in. The change of all of that pressure is going to force air to rush in. Over here, this is exhalation or expiration. Air is being pushed out because in this case, we relax the diaphragm and it's pushing upward. Our ribs are sort of squeezing downward and our sternum is sort of pushing inward. So we're changing the shape of the cavity so that we went sort of like from this to like this. And so when you make a space larger, air is going to rush in, and when you make a space smaller, air will rush out. And that's what inhalation and exhalation are. Muscles involved for pulmonary ventilation. Inspiration requires external intercostals. It's weird, but your internal intercostals help you breathe out, and your external intercostals help you breathe in. So it's opposite. So the external intercostals are going to raise the rib cage up, diaphragm is going to drop, and that's going to make that cavity size larger. Your expiration is going to decrease thoracic cavity size. So your diaphragm will go back up to its dome shape. And your internal intercostals and abs, if you are trying to force a lot of air out, then those can become active and squeezing. Compression, but that's not necessary to normal breath. Normal breath, everything just relaxes and air flows out. We are going to be practicing with this though today in our Physio-X. This is just a diagram to show you the muscles involved: external intercostals, internal intercostals, and diaphragm. Other things to note, which they don't mention all that much, but notice that the sternocleidomastoid muscle, let me pick a different color. Sternocleidomastoid, the scalenes, the pectorals, these muscles, they all attach to the rib cage. And so when you're looking at that, thinking about if someone is breathing really, really heavily or coughing really, really hard, all of these muscles can eventually become sore. And they can spasm. They're all they can all be forced to do the job if the other ones are struggling. All right, now moving on to the actual activity. What you have up here in this picture is a handheld spirometer. And spiro means, I believe it means just air. But this very simple device up top is going to allow us to diagnose diseases and measure respiratory volumes. And then down at the bottom, that picture is someone using one of these in the office. It's a much larger device, kind of outdated actually in this picture. The thing is, these devices are going to be used to measure airflow, but it's kind of hard to do that accurately because your doctor will say, okay, take a normal breath. And if you're trying to take a normal breath, it's hard to know what your normal is because you don't usually think about it. So it's kind of, it's difficult. They're difficult to use, but they definitely have some diagnostic value. Spirometry can distinguish between different disorders. Some disorders that might cause our breathing, we might have an issue with breathing, could be obstructive diseases. This is going to have, these examples would be COPD, so chronic obstructive pulmonary disease, asthma, emphysema. Your lung may be able to hold what needs to be held, but the air is not going through quickly. And so we end up having a lack of oxygen. We have a difficulty with that. So the obstructive part of it is from mucus and secretions and, spasm in the smooth muscle in the airways. So the lung, it's not that the lung can't hold when it needs to, it's that it can't get it there. Restrictive disorders are where the actual lung volume is suffering, where the lung can't do its thing. So sometimes there'd be tumor in there, or blockages, or fibrosis, scarring, that could happen, and that could, actually impact lung volume. So people with a restrictive disorder might have, no problem with airway resistance, but the actual tissue can't hold the volume that people with obstructive disease would be able to hold. These are volumes that you need to make sure you know. This lab, the PhysioX lab that you're going to do, you're going to be using all of these. You need to make sure you understand these. I would write them down somewhere. I would, print out this PowerPoint. I would have your lab manual available. So page 546 is a really good one. Has some good diagrams that I'm going to show you. It also has a nice description and averages. So I would have that open, 546, as you're doing your lab today. The first thing we're going to talk about is TV, which is tidal volume. Tidal volume is the amount of air moved in or out of the lungs during regular, quiet breathing. So again, how are you going to measure this with a spirometer? Okay, do a normal breath. It's like where do I stop breathing? I don't know where I usually stop breathing. So the amount of air moved in and out, just normally. It's about 500 milliliters. So if you look at like a bottle of water, this is 500 milliliters. This is just a little bottle of water. So this is the volume moved in with a normal breath. IRV is known as inspiratory reserve volume. Inspiratory reserve volume is the volume that can be inhaled during forced breathing, in addition to tidal volume. Okay, so looking at your inspiratory reserve volume, amount of air that can be forcefully inhaled after a normal tidal volume inspiration. So what that means is this: you do normal out, normal in, and then after your normal in, which you have to guess, you breathe in as much as you possibly can, and that's inspiratory reserve. So it's a normal out, normal in, and then all the extra after your normal in is your inspiratory reserve. Expiratory reserve is the volume that can be exhaled after a normal tidal volume. So again, normal in, normal out, and now blow the rest of it out. That's expiratory reserve. It's like backup. What do I have after I already did my normal breath? Residual volume is something that always remains in the lung. It remains in the lung. It's 1100 milliliters, always in the lung. It doesn't leave the lung. It's always going to, that volume will always be there. And this is because our lungs have to have some air in order to create a pressure gradient. So residual volume, amount of air remaining in the lungs after forced expiration. So this is the table that's in your book. This is hard because my camera is like backwards. Like using a microscope. There we go. I don't know if you can see that, but that is what I'm referring to. All these definitions are there. So you need to know those four and normal numbers. And then when you take these numbers, you're working to add them together and figure out capacity, total lung capacity, or how much volume we actually have, usable volume. So the sum of two or more of these volumes is known as pulmonary capacity. Total lung capacity, which is the total volume of air that the lungs can hold, total lung capacity is vital capacity plus residual volume, or total lung capacity is tidal volume plus inspiratory reserve plus expiratory reserve plus, oh my gosh, residual volume, sorry. All right, so when you add these up, we're looking at total lung capacity. Male, somewhere around 6,000 milliliters. Female, somewhere around 4,200 milliliters. And those numbers vary huge. There's a huge swing in them. The taller you are, the higher your lung capacity. That's one of the factors. It also varies depending on your size, your genetics, there's lots of things. But these are the numbers that I want you to know. And vital capacity is maximum amount of air that can be exhaled after taking the deepest breath possible. This one's kind of easier to do as far as measuring with a spirometer. So you would breathe as deep as you can and then breathe out all of it. We've all had to do some deep breathing this past couple weeks, I'm thinking. So vital capacity, tidal volume, inspiratory reserve, and expiratory reserve. Those three added up together give you vital capacity. And vital capacity for the average male is 4,800 milliliters. This is in your the page I just gave to you, 536. So vital capacity, average adult male, 4,800, average adult female, 3,100. 4,800, 3,100. Make sure you know these volumes. All right, we have a couple more tests to discuss. Forced vital capacity and forced expiratory volume. So forced vital capacity is the amount of air that can be expelled when the subject takes a deepest possible inspiration and fully expires as completely and rapidly as possible. So it's just regular vital capacity, but you do it as fast as you can. So it's how much force you're putting behind it. So vital capacity, remember, was breathe all the way out and then all the way in, or really breathe all the way in and all the way out. Forced vital capacity is just measuring that, how forcefully you do that. Like it's going to have an impact. Forced expiratory volume is the percentage of the vital capacity that is expired during 1 second of the forced vital capacity test. It's about 80% of vital capacity. These numbers are not there. Forced vital capacity, sorry. Okay, so my next slide is going to help with that. Here's a spirographic record for a male. I like this because it really shows you that, you know, this yellow zone is the tidal volume. 500 milliliters is just like normal breathing, but your lungs have the capacity to do so much more than that. This is how much extra that you can breathe in if you need to. So when you add up all these volumes, inspiratory reserve, tidal volume, expiratory reserve, we end up with vital capacity. And then when you add in your residual volume, we end up with your total lung capacity. All right, and so this is the table that was mentioned a few times now. And then these are some calculations as well on the bottom here. So there are a few formulas that you can use to find vital capacity. Vital capacity should be measured in liters. It can also be measured in milliliters. But in the case of this formula, we're talking about liters. Height is going to be in centimeters and age will be in years. So when you're using H for height in centimeters, you need to make sure you take your height in inches and multiply it by 2.54, which is going to give you centimeters. So 1 inch equals 2.54 centimeters. Respiratory rates are our lecture. We discussed quite a bit about what sections of the brain are going to be involved, and there are receptors that are going to, control those respiratory rates, send that information to these centers. We mentioned chemoreceptors, baroreceptors, and then there's, these are going to detect changes in pH as well. So breaths per minute is also known as respiratory rate. If you have a person is hyperventilating, we could also use the word hypopnea. Hypopnea means it means not enough breathing. So hyperventilating is not enough breathing. I know that sounds weird. Actually, this slide is hyperventilation. Okay, I apologize. So ignore the hyperventilation thing. Go with hypopnea and hyperpnea. So hypopnea is where you are breathing too shallowly. You're not breathing enough to allow for carbon dioxide levels to completely be removed, and that's going to mess with the pH. It's going to lower the pH of the body or the blood. So remember, blood has to stay 7.35 to 7.45. So we would call this acidosis. Acidosis has lots of functions or effects in the body. Changing pH is going to have multiple organs will be affected. Alkalosis is what you'd have with hyperpnea. So this is having too much breathing. So carbon dioxide levels get low, but sometimes they can get too low. So if that happens, pH will increase and get too high, and we call that alkalosis. And that might be from breathing too deeply. So normal respiratory cycle should be like this. Normal in, normal out. We should see 500 milliliters-ish up and down, up and down. We should not see one of these inhalation spiking and then exhalation being normal, and then inhalation spiking and exhalation. Like this is going to cause buildup of carbon dioxide. If you're not breathing, if you're breathing in too much but not out enough, this is not going to work on this particular picture. But if you're breathing, if you're breathing in more than you're exhaling, or if you're exhaling more than you're breathing in, your carbon dioxide levels and oxygen levels are not going to be, you're not going to be able to maintain that homeostatic balance that's necessary for pH. So looking at this, emphysema, acute asthma attack, or breathing during exercise, think about what you might expect in each of these situations when you're comparing them with a spirometer. So these are the things that you're going to be working with today in your lab. So thinking about emphysema, we have a lot of broken walls, broken vessels, not vessels, but broken air vessels, alveoli. And if those walls are broken, then that means that surface area is diminished, which means less capillaries can cling to that surface. And that's going to have a very negative impact on amount of oxygenation in the bloodstream, because there's not enough surface area to do the gas exchange. If someone's having an acute asthma attack, hopefully you would understand that those airways are going to get smaller, and that's going to have a huge impact on tidal volume, on all of your volumes really, and breathing during exercise. Hopefully you can put together the fact that, okay, we're going to have adrenaline rushing, we're going to have airways opening, so your lung capacity can increase quite a bit with exercise. It can approach that 4,800 or your vital capacity. And people who exercise a lot end up having a higher lung capacity for longer. All right. This one's our last slide, and there's a really a section in your activity for the PhysioX today, the activity 3, the effect of surfactant and intrapleural pressure on respiration. So in order to make some prediction questions, you need to understand what surfactant is. So surface tension of water involves the water molecules clinging to each other very tightly. So if you can picture a hollow ball, which is an alveolus, and the inside of it lined with pure water, then these water molecules are going to cling so tightly together that they're going to kind of close in that ball. And so surfactant is a detergent-like molecule or chemical that's going to break that surface tension a little bit so that the alveolus expands and recoils just a little bit, but not a huge amount. If we did not have surfactant, then the surface tension along the inside lining of that alveolus is going to cause this to crash down and close with every breath. And so in premature babies that are born, I think it's 8 weeks early, surfactant has not been created yet. Surfactant secreting cells have not matured yet, and we are dealing with a lung that the alveoli are going to collapse with each breath because we just have this pure water and we don't have that surfactant breaking that surface tension. And so, your activity is going to ask, what effect that might have on lung volumes. Intrapleural pressure is pressure in the pleural cavity. So remember we had our visceral pleura sitting on the lung, and then we had a space, and then we had parietal pleura lining the thoracic cavity. So that's your intrapleural or your pleural space. So the pressure in that pleural cavity changes with each breath. So between breaths, the intrapleural pressure is less than the pressure in the alveoli, and that leads to a negative pressure condition, which leads to a vacuum, and it's going to cause a movement of air. When that pleural cavity is breached in some way, whether there's a break through the parietal peritoneum from the outside or visceral peritoneum from the inside of the lung, and in either event, it could be from an injury or from a pneumonia, we would call that a pneumothorax. And when that happens, we have that pressure on the inside of the lung, that or the pleural cavity, that pressure becomes, it doesn't work right. And instead of having a vacuum effect, we end up seeing the lung itself being impacted by the pressure, and that can lead to atelectasis, which is a collapsed lung. And yeah, so I think that's it. If you have any questions at all, please let me know. Otherwise, I will talk to you soon. Don't forget that we have the Collaborate board, discussion boards that are available. And look on Blackboard for a couple more announcements. And I will, like I said, I'll talk to you soon.